Dr. Mallorie Cracroft is a board-certified OB-GYN and integrative women's health specialist who founded Uplift For Her in Salt Lake City, Utah, to revolutionize care for women. Her clinic combines conventional and functional medicine with a team approach to deliver personalized, whole woman care. She's a doctor, a mom, a busy woman herself, and she understands the challenges of feeling well. And I love this conversation with her. It is really practical and logical and really breaks down what you should really know going into menopause, perimenopause, whether you're in it yet or not, if you're even looking to the future. She gives a lot of really great information, how to approach it with the whole person in mind, and what you really need to know about HRT, what to be afraid of, what not to be afraid of. So it's a really great conversation. I hope you enjoy it. Dr. Craycroft, thank you so much for being with me today.
Oh, my pleasure. I'm happy to be here.
So I'd love to start with hearing a little bit about your story. What inspired you to start to practice integrative, women's health and obstetrics and gynecology?
Yeah, great question. I trained as an OB-GYN and worked as a traditional OB-GYN for about 14 years and loved it, loved my patients, loved what I did. And slowly would start to see more and more patients that I didn't feel like I could help. They would say, "Hey, by the way, I'm tired, or my hair's falling out, or, I don't feel good." And the only thing I could offer them was going to their primary care. And very frequently they would come back and say, they didn't really know what was going on either. Do you have any other ideas? And I'd say no. And around that same time, I happened to learn about integrative medicine and started learning about that. And then got kind of mad, honestly, as I was learning these things and recognizing, like, why didn't I learn these things in medical school? And then I would see these same patients that weren't getting better and see these other little clues and try to bring them into my old practice, but it just wasn't working because of the amount of time that you have. I'd be like rushing off to deliver a baby and doing this 3 minute, 4 minute visit and just didn't really have time to dive in. So it was really quite happenstance. It was really just someone else suggesting. A colleague of mine was like, "Oh, you should check out integrative medicine." I was like, "Sure, what for? I don't know what that is." And I just jumped in and was like, what is this whole field that was not known to me? So I feel like a lot of people have more exciting stories than that. Like someone was ill and they finally found the answer. And fortunately, I don't have that background, but it was really a surprise to me to realize that there are so many tools out there to help patients that I, as a doctor with lots and lots of training, did not know anything about. And so I dove in with both feet and eventually recognized that I couldn't offer that same service within my conventional model because of the short visits and the rush and the also the lovely care that we give to our obstetrics patients, but it can be a little bit all consuming in your day. So I recognized I kind of had to choose for me, one or the other. So I don't deliver babies anymore, but I get to do full-time everything else women's health.
Yeah, amazing. Yeah. And there's no award or anything for having your own personal journey. That's amazing that you
No, I'm grateful,
feel
right?
anything, too serious. But that's so amazing. I mean, I commend you for having that curiosity and that desire to really dig deeper. I think a lot of conventional doctors probably feel that way. They're kind of lost in certain things and, they're not all inspired to go deeper. And it's arguably a harder path to go into integrative medicine
Yeah.
and really have this, it's all just open. Everything is a question and a possibility. And there's not some just standard guidebook to go off of always.
Yeah.
It's amazing because you can really support your patients so much deeper and so much more comprehensively.
Oh,
So
definitely. Yeah.
awesome. Well, on that note, we're talking primarily about menopause and, using hormone replacement, of course, in the context of maybe taking a more integrative, holistic approach with it. To start, I'd love to hear kind of like the top thing that you would want women to know about menopause?
Yeah, it's tricky because there's so many things I would want people to know. I guess the main thing is that maybe there's hope, like you should be listened to. I think menopause and perimenopause can be this tipping point for our health. And a lot of women will come in saying, I'm doing exactly what I've been doing for decades, but suddenly my body's not working. It's not the same. And that's right. That's right. And it's key to understand that so that we can treat the body different. It's kind of like, menopause is the biggest physical change that we go through other than puberty and maybe pregnancy. And if you imagine going through one of those changes and then just being like, well, I know before you were 8 years old and now you're 14 years old and having periods, but your body should probably do everything the same. Like, no, it shouldn't. And we all know that. Like the body goes through this drastic change. Same thing with pregnancy. It goes through these sweeping changes. And if someone said, I mean, I'm doing everything the same, why isn't it working? It's like, because your body's completely different. And that's the same with perimenopause and menopause. Now, it's not hopelessly different, but it is different and it has different needs and it has different vulnerabilities. And the more that we just recognize that we're now treating a different body, the body is in a different state, then we can really dive in and start to help people help their bodies and support their bodies to feel good. Whereas if we just think like, well, you're the same as you were 10 years ago, just a little older, then we're going to keep trying to do things the old way and it's not going to work. And it's just going to be endlessly frustrating.
Yeah, I love that. I love that you bring that up. And I love the comparison to puberty. Because like you said, no one would ever think pre-puberty and post-puberty that things are the same. You'd be like, of course, our bodies are completely different. And then in this phase, we're just disregarding this massive change
Yeah,
that's
it's just a little
happening.
menopause, just a little bit of a change. Yeah.
Just under the rug. Yeah. Well, I love that. And how about on that same note, are there any like big misconceptions that you see with your patients, with women going into perimenopause, menopause?
Yeah, for sure. I think from really the medical community, there's a lot of misconceptions of these changes that we're going through in menopause are natural and therefore should be accepted and tolerated. And I think that's a misconception. I don't think that's true. It is natural. It's natural for your bodies to go through changes, but not tolerated. Like it doesn't have to be tolerated. So I think a lot of women have gone to the doctor and they say, hey, I have this, I have anxious feelings or I can't sleep and I know we hear this a lot, but this is not old news. I mean, just a couple months ago now, my sister who lives across the country from me, so I couldn't help her the way that I would if she was here. So she was telling me about all of these symptoms that she was having that were all classic perimenopause symptoms. And I said, no problem. Here's what you're going to do. You're going to go to your gynecologist. This is what you're going to ask for. It's going to be great. You're going to feel better. And again, this is a couple months ago, not a couple decades ago. She goes to her gynecologist and the gynecologist tells her progesterone is a waste of time. Testosterone is a total marketing scheme. Like people only do that to make money and you don't need any of this. So she was not given the help she needed, but then she was told that she was probably blowing it out of proportion and she was offered an anti-anxiety medication and a sleeping pill. So I think we hear this, but like it's still actively happening that people are not being acknowledged. So in terms of misconceptions, I think a lot of the misconceptions are actually on the side of the medical and professional community, unfortunately. Another big misconception that I see, though, swinging all the way to the other end of the spectrum is I think because social media is talking so much about menopause and perimenopause and hormones right now, that a lot of people think that everything is perimenopause. And I've seen even 32 and 34 and 35-year-old women who come in and they say, I'm in perimenopause. I think I need to get on hormones. And it's like, whoa, okay, now I'm not saying it's not your hormones and I'm not dismissing what you're saying. Like, I believe your symptoms 1,000%. I believe you should feel better than that. But the answer is not always to do hormone replacement therapy. Now, if you're 50, different story, but there's this whole nuanced gray area where it's like that misconception that everything is perimenopause and everything needs hormone replacement therapy. And that I do not agree with. I think there's so much we can do to optimize the body in addition to hormones, and we should. There's so many, I feel like there's a new one every day. There's so many little pop-up menopause shops of like, oh, we do HRT now. We do menopause care now. And as someone who's been doing this for decades, it's a little bit like, so it's not just one thing. That would be like, we do rheumatologic care now, or, we do emergency care now. Like that's a whole medical specialty. And I'm not saying that I or a gynecologist should have like a monopoly on it, but there is more to menopause care than just checking a testosterone level and giving you testosterone and giving you a patch and giving you a pill. There's more to it than that, of recognizing like I said earlier, that body has just gone through this massive transformation. What are all the ways we can support you? Your food, you can support your body with food a little differently. You can support your body with sleep a little differently. There are problems that come up more frequently in that menopausal transition that we can support you with a little bit differently if we are in tune enough and intuitive enough to look for it. So that was a long rambling answer, but the idea of misconceptions, I think, go the whole spectrum from menopause isn't that big of a deal, you should shut up and not worry about it, all the way to everything is hormone replacement therapy and menopause, and the answer is somewhere in between.
Yes. Yeah. Well, no, I think that's great. I appreciate so much that you bring that up because it really just does show how there's so much information nowadays. And it's great
Yeah.
that the conversation is being had
Yes,
about perimenopause, menopause. I
exactly.
love that when people are talking about it on social media, but there is a lot of misinformation. There are a lot of people talking about it who maybe don't know what they're talking about, to put it
Yeah.
bluntly, and
Yeah.
are maybe recommending things that aren't appropriate for everyone. And then, like you said, on the other side of the spectrum, the medical community is still kind of stuck in the dark ages.
Yeah.
It takes a long time for the guidelines to catch up to data,
Yeah.
to, the most advanced research, the most, up to date things that we know. And so there is this experience that so many women are having where, well, I heard this, this, and this, and they're really trying to be more proactive, which is amazing. And then they're going to their doctor and just being dismissed or
Yeah.
being, given the wrong information or being, made afraid of certain treatment options. And it
Yeah.
really, yeah, it should be landing somewhere in the middle or kind of blending all of them to give better information, but really up to date, accurate information and giving that
Exactly.
support.
Yeah.
With that, you started to mention it, you kind of like maybe how we should be approaching menopause. What is the way that you maybe approach it? I know it's different for each woman, which I think is appropriate, but kind of like how do you look at things? Maybe what are the aspects that you're really talking about? You started to mention some of those.
Yeah. I like to first look at the big picture, obviously. So it really depends on what their age is, what kinds of symptoms they're having, what their cycles are doing, and to some degree, what other reproductive issues they've had in the past. Sometimes that will sort of shade it a little bit. If they have perfect periods and no problems, and now they're just starting to have like hot flashes and anxiousness and sleep disturbance, then that's kind of one way to approach. But if they've had endometriosis and if they've had especially a complex reproductive history like breast cancer, or they've had ovaries removed, or they've had endometriosis, or sometimes those will kind of play into the conversation. But generally speaking, there's sort of maybe 3 different phases, and I might even say 4 different phases, although these are just mine, that I don't think they're defined anywhere else. But that very first phase would be that group that I mentioned of like, they're kind of acting like they're perimenopausal, but I kind of think they're a little too young to be perimenopausal. Now, that's not defined because absolutely there are some women whose ovaries are shutting down and failing even very early. But I just believe in the ovaries a little bit stronger than that. I think ovaries are fighters. I think they want to keep going, but they get taxed and they get stressed. I call them the canary in the coal mine, is the idea of like, if the body is under assault or if the body is under deep stress, then the ovaries are one of the first things to shut down. So you may be acting like you're in perimenopause, but in that case, in those early younger women, I kind of want to focus more on taking the strain off the body and on rehabbing the body and making the body as strong as possible instead of just adding hormone replacement therapy. So that's kind of that first group in age. The second group then that I have in mind, I call it early perimenopause. And for me, that's like maybe late 30s to maybe mid 40s. And these people, when you're first going through the perimenopausal transition, will usually first have symptoms of progesterone deficiency and sometimes of estrogen excess, of the estrogen actually going high. So those are people whose really periods are just a mess. They're super heavy, or they're super painful, or they have terrible PMS and kind of out of the blue. Now, there are obviously people who've had that their whole lives, menstruating lives, but these are women who have had like a shift. Once I turned 40, those periods got way wonky. Those are people that I'm thinking early perimenopause. And I'm going to be focusing more on progesterone, testosterone, and diminishing estrogen actually. And
Mhm.
if we don't do that right, and you say you're perimenopausal, we should give you estrogen, right? That's what we hear. That's what social media tells us. A lot of people actually feel way worse. It
Mhm.
can make their periods worse. It can make other symptoms worse. So I like to start first with progesterone and getting things settled, and testosterone if necessary, and then seeing what they still need from there. Then that third group of women is more late perimenopause. They're still cycling usually pretty consistently. Maybe it's starting to space out or come close together, but usually there's still some regular cycling pattern. But they're now starting to have symptoms of progesterone deficiency and estrogen deficiency. And that would be things more like hot flashes and night sweats and some of these more classic menopausal symptoms. So those are the ones that I'm focusing on: progesterone and estrogen replacement, maybe testosterone replacement, and really trying to stabilize there. And then there's postmenopausal, or, menopause and on, that have really stopped having periods. And we're still going to do hormone replacement therapy or talk about hormone replacement therapy in the same way as that late perimenopausal group, but we might do it a little more assertively. We might focus more on a little bit going up on doses instead of just doing the bare minimum at that point.
Yeah, I love that.
And
Yeah.
then, of course, sorry, I'll add to that, it's never just that. So like I said before, if you are going to a clinic that is an HRT clinic, and that's hormone replacement therapy, if that's all that you're doing, I think you're being underserved. I think we should be talking also about just the health foundations of, great, let's fix the hormones, but also like, let's prepare you for this second half of your life. The first half of the life is based on growing and having babies and getting stronger and taller and all of these things. The second half of the life is sort of sloping downward. So we need to be working on bucking that a little bit, like trying to slow that slope as much as possible to say, yes, of course, this is the second half of my life. And of course, it's going to be quieting down more than growing and getting bigger. But that doesn't mean we have to just accept it and be like, well, I guess I'm granny on the porch now at 51 doing nothing. Like, no, you can still have a vibrant and rich life in your 50s, 60s, 70s, 80s, 90s. Like, you can, but we have to really be conscious about making those shifts. Once you get to 50, we have to do it differently. And so if you're just getting HRT and then checking your own personal like menopause care box, I think you're being underserved. There's so many other ways that we can serve you. So that's my approach to menopause, is first kind of seeing where you're at in the process, really talking about HRT, seeing if that's the right option for you, and then going the next level deeper and talking about health foundations. And I call them health foundations, those really pivotal things that support our health and specific to you and your stage of life.
Yeah. Perfect. Yeah, I think it is. I agree with you. It's so helpful to know sort of what general stage someone is in.
Yeah.
And I do the same categorization because it really does change,
Yeah.
like you said, how assertive we're being with suggesting certain things, what types of changes and things we're offering. So that's amazing. And such a great point you bring up of, yeah, life is getting small, or the way you put it, like a kind of downward slope, but you really can study that slope and still feel vital and amazing and have
Yeah.
energy. It doesn't have to feel like everything's declining. With those health foundations, I mean, those are so foundational, for lack of a better word, for our overall health. What you mentioned some of those, but just to kind of point those out for people who maybe aren't as familiar, things like diet, sleep, you mentioned, movement. What
Yeah.
other things are you really focusing on with your patients for the foundations?
So I use 6 main foundations. You just mentioned the first 3. I use the word nourishment because I don't want people to be thinking about cutting calories or cutting things out. I want to be constantly focusing on how are you nourishing your body as it ages or as it's growing, like whatever stage you're in, how are you nourishing it for that phase of time? Movement is the second one. Gut health is one that I talk a lot about. Sleep, stress management or nervous system support, kind of what are you doing about fight or flight in your life? And then the 6th one is, it for me, is detox support. Like, what are we doing to support our detox? Social connectedness is in there somewhere too. So those
Yeah.
are the main ones.
Awesome. Yeah, those are so important for our overall well-being and can play into, you know, the way that we're
Everything.
experiencing even hormonal things and the way
Exactly.
yeah, uh,
Yeah.
like you
And
said.
I'll say to that, like, that's not just warm fuzzies. Like, there's data showing that
Mhm.
women who exercise have fewer menopausal side effects, symptoms, right? That women who meditate or have some amount of nervous system support, or we use self-care. I kind of hate that phrase because it's like means so many of the wrong things, but women who have some sort of that nervous system support live longer, utilize the healthcare system less. Like there's good data. This isn't just warm fuzzies like sleep's a good idea. No, there's data showing decrease in just about every chronic disease state when you get deep restorative good quality sleep. So and that's where it goes back to like menopause is hormones and it is HRT, but it's so much more than that. And we can support so much more than that. So there's good data behind all of those pillars. It's not just like, that seems like a good idea. Like it's legitimate.
Yeah. Yeah, such an important point to note that. I mean, even just like you mentioned, how many friends we have, like having a social connection, that also impacts our mortality and, how long we live, the quality of our life. And that tends to suffer in our later years as well.
Yeah, and that's why I love getting patients when they're like, that's part of the beauty of getting to build a relationship with patients in their 50s and 60s and 70s is you get to check in. Like in my mind, that's what an annual exam should really be. Like we should be going through those pillars. Sick visits or those intermediate visits are where we're doing HRT and hormone adjustments and everything else. But really that annual visit should be a check-in of those pillars and to say like, how's your social life? Are you getting out there? I know it's hard. I know you're tired. I know you don't want to, but like, just like I want you to exercise, even though it's hard and you're tired, I also want you to get out there. So can you join a book club? Can you take a pottery class? Can you have a friend over for dinner? Like we can help encourage that. And that's healthcare, right? Like that's health and wellness care in its best form is that we should be able to encourage that. And I do think it's hard to do all along the way because when people are sick, there's just so much to talk about. You don't necessarily have time to be like, tell your social life,
Yeah.
But when we are stable and we've gotten things in place, it's really wonderful to be able to go back to those basics and say, how do I help you live the longest and live the best?
Yeah, I love that. To go back to some of the hormone replacement, I love that you kind of like put those in those phases of kind of what you're thinking about. I love that you mentioned testosterone too, because it's one that sort of gets dismissed a lot of the time. With that one in particular, I wanted to ask you just kind of like, what is your approach to maybe testosterone therapy? Are you looking at levels? Are you doing it based off symptoms? Both? What's your approach there?
Yeah, I find progesterone symptoms, like progesterone deficiency symptoms, are pretty clear. Estrogen deficiency symptoms are pretty clear if you know what you're looking for. Testosterone's a little bit all over the map because a lot of testosterone symptoms feel like estrogen symptoms. So I love testing testosterone. And I think testosterone is really surprising. We think of it as like it goes down as we go through menopause and it goes down as we age. But as I've been testing more and more women, you find really low testosterone levels in really young women. And so one of the things you want to think about, again, it's looking at those phases. If you're on the younger side of this perimenopausal curve, you're in that 30s range, even 25, I've seen it super low. If you're at that age and your testosterone is low, we've got to do something about that, not just give you testosterone. Like, yes, we can give you testosterone, but that's not the point. Like, why does your body feel so stressed out that it's not giving you adequate amounts of testosterone? And then you're feeling bad. Like, yes, I don't want you to feel bad, but also I want to know that's that whole root cause within functional medicine, right? Like, why is your body so strained and stressed that it feels like it can't do that? So in those earlier years, I've started testing testosterone on just about everyone now. And when you find it, in those earlier years, I use it more as a warning sign, like, whoa, 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 what's happening there? I still may give testosterone replacement, but I'd rather not do that first line. I'd rather say, like, if this is off, let's fix stuff and then come back to it. In the early to mid 30s, I'm a little bit more likely to replace it. Late 30s, a little more likely to replace it. 40s, yeah, you can have it. Like, we're still looking at that, like, in your early 40s, you really should have reasonable testosterone levels. Like there's no reason your body should be totally shutting down. But I also think if you're going through all sorts of symptoms, I'm more likely to be like, okay, I'm still going to worry about those foundations and still see what's straining and stressing your body, but also give that testosterone. And then as women age, then I'm much more likely to give it. So I do use the lab as a guide. I wouldn't say it's the end all be all, But if testosterone levels are undetectable, which it happens all the time, or if they're 10, then I'm more likely to say, let's try it. I also do use that level as a starting point. So if their testosterone is so normal is on the lab result, it will say 10 to 40, or some places 10 to 50 or something like that. And if the level is 20, but they have symptoms that are consistent with testosterone deficiency, like low sex drive, or feeling like they can't push it as hard at the gym, or they're dealing with fatigue, or maybe a little mood fading, the mood isn't great. Or one of the symptoms of testosterone deficiency that I think about is, I call it black or white living. If you're, you feel like you were this vibrant, colorful creature, and now you're the same creature, but faded, like a more washed out version, that can really get better with testosterone. So if I have a middle-aged woman whose testosterone is 25, I might give them a smaller dose. If I have someone whose level is 0, I might give them a higher dose. But either way, then we're coming back and dosing according to how they feel.
Yeah, great. That's such a good point, because I see that too in my practice, where someone might be kind of in the middle of the road, they're in normal range, but for them, it seems like their body is just like they're having enough symptoms that seem consistent with that. So it's really, tying those two
I
together.
don't think it's the clear black or white cutoff.
Yeah. And now testosterone replacement is sort of a tricky one. I've seen so many patients come to me who have sky high testosterone levels and symptoms of too much testosterone because they have gone to maybe one of those HRT clinics that isn't looking at the full picture. How do you dose it? It is hard because there aren't really female doses that are FDA approved. Usually we're doing doses of the male versions. So how do you approach that?
I start most women with a transdermal cream or gel. Kind of depends on insurance coverage and getting it through regular pharmacy or getting it through a compounded pharmacy. But I start them at about 2.5 milligrams to 5 milligrams a day and just go from there. Sometimes I'll switch to a sub-Q, like an injection, but I find most people just aren't super excited to do a twice weekly injection. So I usually start with the cream. What was your question? Just how do I dose it?
Yeah, with dosing testosterone. Yeah. I feel like it's more again, it's sort of like the Wild West when it comes to some of the hormone therapy, especially with testosterone, because it is FDA approved for male doses.
Yeah,
I
and
think that's why I
here's
see
what
a
I've
lot of the overdosing of it because people don't know how to dose it appropriately.
well, yes, and yes, completely. They think if a little bit is good, then more is better, right? And the thing is, a lot of women really do feel quite good on higher doses of testosterone. And really, we don't know the complete upper range of safety for testosterone. Like, it may be safe to dose them high. I think if you're dosing to a male range, that feels wrong.
Mm-hmm.
Like, I don't want my testosterone in the male range. So that's probably an upper limit. But really, for me, from a full woman context, I think it's really easy for folks who are just doing HRT to be like, oh, we gave you some hormones and you don't feel better. Let's give you more. You still don't feel better. Let's give you more. From a functional and integrative standpoint, we get to say, I mean, we could go up a little more on that testosterone, but what else is going on? And I will say, I don't have a lot of women who don't feel better because we're not just doing HRT. We're managing their sleep and we're managing their food and we're managing their inflammation and we're managing their gut health. And those things make a difference. Now, if you have someone who's 55, doing those things is frequently not enough. You want hormones on board too, but you usually don't need sky high doses of hormones if you fix the other things. But if you're going to someone whose only knowledge base is to give hormones, then there's the expression, right? To a hammer, everything looks like a nail. If that's what their hammer is, then they're just going to keep giving you more hormones. And then you do get women on super high doses. And I haven't seen very many who are successful long term. I think very frequently they end up saying, I felt good for a while and now I don't, or I was getting hair growth, or I was getting hair loss, or I was getting acne. And once we get to those points, it's a little bit harder to kind of go backwards. So I'm a start low, go slow, fix multiple things as we go. And most women feel really, really good.
That's great. And then you mentioned with progesterone starting there first when the estrogen is running higher, the progesterone is suffering, and then kind of switching into estrogen and progesterone. Do you have a strong preference on how you start people with that as far as the form, what kind of thing?
Yeah.
you're giving them?
Yeah, I think physiologically, we know that one of the first hormones to droop is progesterone. So that's as our egg quality goes down, as our ovulatory um, capabilities go down, then the progesterone will go down. So it's easy to give people progesterone. That one is, if people are having symptoms of progesterone deficiency and you give it to them, they feel better. So I will typically start with oral progesterone. Occasionally we'll do transdermal or something like that if they don't need estrogen yet and they just have a couple little symptoms, but I really prefer oral. Oral progesterone is better. It has a greater effect on some of the neurologic symptoms that we have, like trouble sleeping, like anxiousness and anxiety. And you lose that if you take a different form of progesterone, like a cream, or sometimes we'll place it vaginally, but then you lose those calming effects that we really love about progesterone. So progesterone is just about always a capsule form for me. And I usually start with a lower dose and tell them to try a low dose and a higher dose and see what they like, and see where they land there. And then eventually when we're adding estrogen, I usually start with an estrogen patch. It's FDA approved, it's cheap, it's easy. You only have to do it twice a week. And I would say at least half of my patients do great with that. Occasionally I get someone who's sensitive to the products in it, or who has weird spotty bleeding stuff that they really need daily dosing. Some women's bodies just don't like that slope of release of the hormone. The patch releases a little bit more the first day and then a little bit less for the next 3 days. And then you put on a new patch and it's a little bit more and then a little bit less. And most people can't tell, but occasionally you get someone who's very sensitive and they just really do better with a steady state dosing. So those people, I'll switch to a daily estradiol cream. Vaginal estrogen is another delivery form, and we do a lot of vaginal estrogen. That's really more for vaginal symptoms, not for systemic support. So I'm typically doing those depending on their symptoms. If they have vaginal symptoms, you can always have vaginal estrogen, right? But if they don't have any vaginal symptoms or the symptoms are mild and they have a bunch of systemic symptoms like hot flashes and night sweats, then I'll start with an estrogen systemic replacement like patch or cream and keep them on that, and then add the vaginal estrogen back. There are pellets and there's oral estrogen. I'm not a huge fan of either, although I'm not completely opposed to either, which is probably an unpopular opinion. I think that for estrogen in a pellet form, certainly it's a terrible place to start. You don't ever want to start with estrogens in a pellet, because once it's there for 3 months and they're just guessing at the dose. And I have dealt with enough women and their hormone replacement that I will tell you, you cannot just guess at a dose. You have to guess and then adjust and then adjust and adjust. And if women have unpleasant side effects from overdosing that estrogen, they're not happy about it.
Yeah.
So doing a pellet right off the bat is a terrible idea. There are some women who get really stable on their dose and will switch to a pellet at that point. And I think it's okay, although we don't have the same safety data on pellets, and it's just way overpriced. So I don't offer pellets and I don't recommend them, but if someone's on them, I'm not going to panic if they're doing well on them. I mentioned oral estrogen. Oral estrogen is what we used to do all the time. And then we found that it increased the risk of clotting, so heart attack, stroke, and blood clots. And so then we said no oral estrogen, although the North American Menopause Society does not say no. So it's still within some people's guidelines to offer oral estrogen. The data is kind of interesting, kind of mixed about protective effects actually of oral estrogen over transdermal estrogen in some ways. But I think most people really are leaning towards transdermal estrogen. And that's what I start with because of the lower risk of clotting. So I will do transdermal estrogen primarily. But again, if someone comes to me, they've been stable for years on an oral estrogen, I'll talk to them about the slightly increased risk of clotting. But there's a little bit of we call it a stress test there, right? If they've had, 5 babies and they've had birth control pills and they've been on oral estrogen for 10 years, that's a pretty good stress test of whether you're going to clot or not. Now, it's not perfect, but it's pretty obvious that you're not a really hyper clotter. So I think in those cases, if they're super stable and they don't want to switch off of a patch, I'm not totally opposed to keeping them on it.
Yeah. I'm glad you bring that up because I think there's so much fear around HRT in the world due to some poorly interpreted studies. and especially with the oral estrogen, we've been so afraid.
Yeah.
For me too, it was just recently that I learned that I shouldn't. I can't speak specifically to the amounts, but I believe the risk of clotting is still far less than birth control pills, which we give
Oh,
out
yeah.
candy.
Yeah.
And while the risk goes up a little bit with age, it's still a lower risk than what we've been doing their entire life, or for a lot of
Right.
women, a big chunk of their lives. So
Well,
absolutely.
and a ton lower than the risk of clotting in pregnancy.
Yeah.
And people go through that, without being like, you're an idiot for getting pregnant. You're going
Mhm.
to die from a blood clot. Like
Yeah.
now you combine that with cardiovascular risk and a risk of clotting. So I'm not saying it's nothing, but
Right.
I do think there's so much in social media and in really in medical care in general that's so black and white and so fear based. And one of the fun things that I get to do as an expert is I get to stay in the middle. I get to have nuance and I get to personalize that to the patient and say, this is what may be best for you. And as long as you understand the risks, then you get to decide. Why would I decide sweepingly across the entire country of this is what everyone does because of this percentage of risk? Like it
Yeah.
just doesn't really make sense.
Yeah. Yeah. That's great. And on that note, I mean, maybe to speak to some of the risks that are present with hormone replacement. I mean, we talked about clots. I think another one of the ones that I hear from patients a lot, their fear is of breast cancer.
Yeah.
Can you speak to that as far as the risk when it comes to hormone replacement therapy and maybe the different types of hormone replacement?
Yeah. I think this is another place where people speak in sweeping absolutes. The fact is, I don't think it's clear. I don't think we really know. There was a recent study in just the last 5 years, I want to say 2021, that really looked at long-term estrogen use in postmenopausal women and found a decrease in all-cause mortality. That's a hard study to argue with, that women died of everything less when they took estrogen replacement therapy.
Hmm.
That means cancer and multiple cancers, colon cancer, breast cancer. It was a decrease in cardiovascular risk, a decrease in osteoporosis, and maybe a slight decrease in dementia and stroke prevention. So that's a really hard thing to argue with and really speaks to the safety actually of this. I think another thing arguing in terms of safety of these hormones is just what you mentioned. Our bodies have had way higher levels of these hormones throughout most of our life, since we were 10 or 12 or whatever. And so the idea of like giving these hormones back and totally increasing our risk is a little bit nonsensical. Like it kind of doesn't make any sense. But in terms of the data that we have behind it, you can actually find a pretty big study for or against HRT. And I think that the longer time goes by, the more refined we get in studying that. But these studies take decades because when you look and you say, like, women who took estrogen for more than 10 years and women who took estrogen for more than 20 years, that's a 20-year study. But then you have to see until they die and say, what did they die from? And did they die earlier than their peers who weren't on estrogen? So this data, a lot of times we hear like doctors are so behind the times, and yes, that's true sometimes, but also this data is slow coming. And if we look at this data, the majority of it is still based on conjugated equine estrogens. So that's not the estrogen patch that most of us are using now,
Hmm.
and progestins, so not progesterone. And so it's still the data that's even, in process is still the data of what we were doing 20 years ago.
Hmm.
So we don't know about the risks. I think generally speaking, the most current data that we have suggests and supports that hormone replacement therapy, when managed appropriately and delivered appropriately, is very safe.
Hmm.
I think we can also say that it's certainly safer in most women than not having hormone replacement therapy.
Hmm.
There are risks as we age, and those you're kind of living in just an increased risk time of life, sadly, but we can diminish a lot of those risks with hormone replacement therapy. There still is question about increased risk of breast cancer. There was just recently a study that came out showing, oddly, that so the Women's Health Initiative from 20 plus years ago now, the Women's Health Initiative showed increased risk of breast cancer with progestin, so synthetic progesterone.
Hmm.
But then the most recent study then showed an increased risk a slight increased risk with progesterone. So again, I don't think we know, but I think that most of the data is leaning more and more and more towards the ultimate safety of hormone replacement therapy. I think if someone was like, I want to do everything I can to decrease my risk of cancer, then avoiding HRT would not even be on my top 5 things to do,
Mhm.
right? I think you could, watch your alcohol intake, you could watch insulin resistance, you could exercise, you could get sunlight, you could make sure that your sleep is good. All of those would decrease your risk of cancer more than the likelihood of hormone replacement therapy increasing your risk of breast cancer. And even that is probably a statistical error and or different types of hormone replacement. So it's a long conversation. And I think that the majority of the counseling that I give patients is it's very, very safe. And I stand by that. And I would take it myself and I would prescribe it for my family members without worry in most cases. But I can't say we know 1,000% because the data is weird. And as we learned from the Women's Health Initiative, statistics matter. And you're really relying on a statistician to interpret that data. And in fact, with the Women's Health Initiative, when they reinterpreted the data changed completely. Like it changed from dangerous to protective.
Yeah.
So that's bad statistics. And I think that data, you can do a lot to make data look a certain way, unfortunately. So,
Mhm.
so more to come. I think we'll keep learning, especially last thing I'll say about that is when you look at these studies, they were like 4% of women. So when they were following these women, only 4% of them were even on HRT. 4%. That means if you find 100 women next to you who are absolutely miserable for menopause, only 4 of them are taking something for it. And
Yeah.
then you follow those ones. And that's the data that we have. So more and more, as we're starting to get more women on hormone replacement therapy, I think we'll get that data faster.
Yeah. Well, yeah, you made such amazing points with that of, again, a lot of the data is based on a lot of different, there's so many different factors that play into
Yeah.
it. For those who aren't familiar, the Women's Health Initiative is basically the study that, put fear into everyone, including all the doctors, that we shouldn't be doing HRT. And like you said, they reanalyzed it. And it seemed like, I think my understanding with it is there was some increased risk of breast cancer, for example, but still the all-cause mortality did actually point in the direction of being lower on hormone replacement therapy, even with the less safe hormone replacement, basically.
Well, it depended on which one you were looking at. So the progestins showed increased risk of breast cancer, but the estrogen only arm showed it decreased risk of it showed protective
Yeah.
benefit to breast cancer. And that has continued to be shown over and over
Yeah.
is actually taking estrogen to be protective for breast cancer. Progesterone is really where it's a little dicey, but in my mind, the progestins, the synthetic progestins, like don't do it. Like just
Yeah.
don't do it. They
Yeah.
don't make you feel good. They don't have the same benefits. The only thing they do for you is to balance out the estrogen. And maybe some studies show an increased risk of breast cancer and some show a decreased risk of breast cancer. So just leave the synthetic progestins out.
Yeah.
I don't fully know if I support this study that says that progesterone in conjunction with estrogen increases the risk of breast cancer. I think there's enough conflict there that we're not at the final answer
Yeah.
for
Yeah.
that
I agree
one.
with you. I mean, it doesn't even make sense logically in my brain
No,
of how that would be the
no.
case. And so I agree. I think there needs to be more data. And I think you brought up the most important point is that each woman should be having an informed conversation with her doctor
Yeah.
about what is right for her. What are her risks of, for or against these different treatment options, looking at all the treatment options, not just one, and really making the most educated decision for themselves.
Yeah.
Yeah.
Yeah. But not based on fear. I think that the more we can do to support our bodies, like that's good. That's going to be good. If it makes you feel good and it makes you happy, there's so much data to support the use of HRT that I don't think it's a very scary concept, honestly.
I agree. And like you said earlier too, when you're dosing low and slow and monitoring their levels rather than just slapping them on with some
Yeah.
hormones and then letting them out in the wild without knowing if it's, right, if they're having symptoms or not. I think if you're doing it appropriately, then it is so safe. Their levels are so much lower than they were their entire lives, and they're just feeling so much better. And their risk is being mitigated to things like osteoporosis and cardiovascular disease and
Yeah.
dementia and all these different things that are really, like you said, our risk really does go up for all of those things in menopause. So,
Yeah.
yeah. Well, with that, any final tips that you would like to leave our listeners of how they can support their health, maybe starting now, how they can approach their health if they're going into menopause?
Yeah. I mean, I think when I can get my hands on my 20 and 30-year-old patients, like that's how we prepare for menopause. Honestly, it's because the more that we decrease the wear and tear in our bodies, the better that menopausal transition can be. Now, that's not to say if you're going through menopause and it's crappy that like it's your fault and you should have done better. That's not at all what I mean. But the more we can support the body to age more gracefully, then the easier that menopausal transition is going to be. And those go back to those foundations: sleeping and managing stress and getting some movement, managing blood sugar, eating nourishing foods. Those are things that really do smooth the body's aging process by helping it to be more resilient and less strained. I think as we're going through the menopausal transition, honestly, HRT is probably the main thing that I would tell people. If you're miserable, I'm all about lifestyle and we should do lifestyle, but I have many patients who do lifestyle who just don't feel good. So do lifestyle before HRT, do lifestyle after HRT. Yes, do lifestyle, but also really consider if HRT is the best option for you, because it just is one of those things that as a doctor often makes me look like a magician. Is, people come in and they're so miserable and I replace their hormones and they feel so much better. I hear all the time, I feel like myself again. I never knew if I would get back to myself. My marriage was really strained and now it's fine because I'm myself. Or I feel like I got my life back. Like these are things that are worth it. And so honestly, like HRT is probably my main advice for someone going through the menopausal and perimenopausal transition.
And with that, where can people find you if they're looking for some more support?
Yeah. So I have an in-person clinic in Salt Lake City, Utah, and it is called Uplift for Her. And we have a website. We also have some free resources on there that people can check out. I have a podcast as well that's called Uplift for Her, where we talk all things women's health and a lot about menopause and hormones and all of the things from a functional and integrative perspective. And then on Instagram, Uplift for Her again.
Awesome. Well, thank you so much again for being here. Again, you gave so much great information that I think is going to be so supportive of women's health for all of those who are listening.
Oh, good. My pleasure. Thanks for having me.